The Chiefs have assigned me basically all of neurology that doesn't shake in one lecture. So let's see how this goes. So stroke, TIA, cervical aortic dissection are basically neurology and cardiology are practically the same thing. So no conflicts of interest. We're going to scream through these slides, okay? There's a lot to cover. So I'm basically going to argue that hemorrhagic stroke is essentially an aortic dissection that happens in the brain, that a major stroke is basically a STEMI, that a lesser stroke, which is the stroke that happens to the other guy, is basically an NSTEMI, and a TIA is unstable angina. And then for some reason, I also have to talk about cervical artery dissection because that wasn't enough to cover. So I'm going to send you this in an email. It's too small to read. You'll get it later. This is basically the flow chart of how I think about stroke-looking stuff. And this is going to be a lot like a fire hose. This is going to go quickly. Sorry. So strokes are terrible. If you didn't know that, you're dumb. There's nearly 1 million of these a year. It's the third leading cause of death. And as far as disability goes, there are a few conditions that even come close. Only about 15% return to baseline. 15% can't talk. And then a huge number of these folks are heavily dependent upon their family or go to nursing facilities. So let's start with the case. Got a 63-year-old female, trouble talking for about an hour, moderate headache, has a history of atrial fibrillation, is on warfarin. What are you worried about? Brain bleed, right. Because stroke shouldn't cause headache. I know that sounds basic, but a lot of people forget this. They think that ischemic strokes cause headache. They really don't, okay? So if you have something that looks like a stroke and their head hurts, be strongly suspicious of a hemorrhagic stroke. So everyone gets a CT scan, okay? If it looks like a stroke, you get a CT scan. You start with a non-con right now because that's faster, okay? 10 years from now, they might be able to get you quick enough MRIs, but right now, everyone's going to be getting non-cons. So everybody gets a scan, okay? So you see this, okay? Now, I'm no rocket surgeon, but that looks bad. So remember, bright white stuff is probably blood. So get the lytics ready? No, do not do that. So this is a hemorrhagic stroke. And what I'm going to argue is that this is basically the same thing as an aortic dissection that just moved from your chest up to your brain space, okay? So what do you do for an aortic dissection? So you do a heart rate control, which we don't really care about for this particular disease, but you do worry about blood pressure control. For aortic dissection, that's less than 120. For this, it's perhaps less than 140. You'll see why I say perhaps in a minute. You also give analgesia to both because if you're hurting, it's going to be, one, hard to get blood pressure control. If any of you guys have ever tried to control someone's blood pressure while they're having 10 out of 10 pain, it doesn't go very well. So you're going to be using some analgesia. Severe cases may require surgery for both of these. So proximal aortic dissections require a cardiothoracic surgeon. Really severe hemorrhagic strokes often require decompression from the neurosurgery folks. And then you're going to reverse anticoagulation in practically the same way. So the study that made me say that maybe systolic blood pressure 140 is the INTERACT 2 study. There was an INTERACT 1 study that had the very unsatisfying conclusion of if you control the blood pressure aggressively, the brain bleed is smaller, but the patient has just as crappy of an outcome, which is not very satisfying at all. So they did a larger study called INTERACT 2, which compared a systolic blood pressure of less than 140 to systolic blood pressure of less than 180. Tons of problems with this study, not very good, and technically negative. So a Chinese study using urapidil, which we don't even have this in the United States. That was what most of the patients received. Okay, it was a multi-centered study. Not all of them were receiving that drug. But it's really hard to say that, oh yeah, this study that didn't even achieve statistical significance is something that's going to be practice changing. However, there was a pretty good trend towards benefit of both disability and mortality, and there wasn't any evidence of harm. So why not? Shrug. But if you talk to a lot of folks, they're going to act like this is the definitive study that proved that we should be lowering the blood pressure. It didn't. It was a negative study and is really in desperate need of being redone. But as is common in the case of stroke literature, when you get a negative study, if you sort of bend over backwards and say, oh, it was positive because of one of my secondary outcomes, then you can argue it's standard of care and say that you shouldn't study this anymore because that would hurt patients, which is exactly what happened here. There aren't a whole lot of studies that are actually asking this very important question of how low should we drop the blood pressure. But a lot of people want to drop it to below 140. So what are the differences? Well, basically you want the head of the bed up, and that's the only thing you really need to know, okay? So get the head of the bed up to 30 degrees every time, not because it matters if there's not increased intracranial pressure, but because you want to get in the habit of it. So unless they're coning or something like that, this is probably not a huge deal, but every time you have someone with a brain bleed, every time, get that head of the bed up to 30 degrees. Those handful of patients that benefit from it, of this essentially free intervention you're doing, will benefit from that habit. You can also use mannitol, which is probably better than hypertonic saline. People have gone back and forth about this, but mannitol is probably slightly better. There's actually a trend towards patient harm when you routinely use mannitol in this patient population group. But if someone's coning, go for it. Why not? But those are going to be people that are going to be intubated and really not doing well in general. Seizure prophylaxis is also very controversial. If you have a seizure, you get bad outcomes. Giving this drug after you have a seizure, like if you give Keppra or something like that, decreases further seizures. Please note I didn't say that giving this drug improves patient outcome, because actually when they looked at people getting phenytoin, they actually did worse. No one knows why. Could be because phenytoin is not a totally benign agent, but when they've actually asked the question, patient outcomes slightly got worse, which is why I don't like phenytoin for these folks. If I'm going to use anything, I'll use levetiracetam or Keppra for you sellouts. Yeah, that's for you, Clay. That's for you. All right. So basically, intracranial hemorrhage is basically aortic dissection with the head of the bed up. Everything else, we don't know what to do. Just act like it's the same and apologize to cardiology if you paid the wrong service. So how do you treat increased... sorry, I couldn't help myself. When you Google ICP, you'll get insane clown posse sometimes. That definitely avoid that for all patients, including people with increased intracranial pressure. So you're going to treat ICH with ICH. So lower the ICP, coagulate by reversing any agents they're on, and head a bed up. And then, of course, always avoid insane clown posse. For those of you who do not know who Insane Clown Posse is, do not look them up. Do not listen to their music. Just be happy that you don't know what those folks or their fans are. Orders for these folks. I'm a big labetalol fan. Sure, nicardipine cool and all that. Labetalol is also great. You can really argue either way. There's not clear evidence for one or the other. Nimodipine is an ICU drug. Don't worry about it. That's going to happen later on. Don't give it in the ED. It's an oral drug. Doesn't make a lot of sense for us to be using. But if you're in the trauma ICU or whatever, it may be something that happens a few days later. Head a bed up. Always anticoagulate. I really like FFP and vitamin K more than PCCs because of local experience with that. I like to give a lot of fentanyl. If you're worried about their mental status to where you can't give them fentanyl to control their pain, you should have intubated this patient. Go ahead and do that. Then give them the fentanyl. And then consider loading with Keppra if you're worried about seizures. That's really debatable. And mannitol if you're desperate. I would start with at least 10 to 20. Usually these folks are very hypertensive. I think nicardipine would be very elegant if they didn't have a tachycardia with it. And that's basically what I would do. If they have fast heart rate and high blood pressure, I give labetalol. But it would be a 10 to 20 milligram IV bolus is what I would start. It seems fairly hard to actually drop these people too low if they're super high. But if they're a little soft, it does happen. And therein lies the rub, is that this often is a younger population than some of those, but it depends on what's causing it. But also look at their drugs. If they're on a beta blocker, be very careful about swapping over and using nicardipine, because then you're adding a beta blocker to calcium channel blocker and vice versa. So look at their meds and try to match like with like.